Good afternoon, everyone. Thank you for joining us today. My name is Melissa Stagnaro. I'm the Director of Fundraising and Business Development here at UHS Chenango Memorial Hospital. It's an honor to moderate today's session. We are very excited to continue our Lunchtime Learning Series with a special presentation on rheumatoid arthritis by Colette O'Brien. Colette is a certified nurse practitioner with UHS Rheumatology in Vestal, and as you'll see, this is a topic that is near to her heart as well as an area of professional expertise. I'm truly grateful this series has given me a chance to meet Colette. She is a very special person with a true passion for both her patients and her specialty. She was inspired to pursue a career in healthcare by her mother, herself a nurse anesthetist, and yes, I practice saying that. Colette has spent her entire professional career within United Health Services. She started as a nurse's aide right out of high school, and then following in her mother's footsteps, she went on to become a nurse. She earned her undergraduate degree at Elmira College and then continued on to do her graduate studies at Binghamton University's Decker School of Nursing. She is board certified through the American Academy of Nurse Practitioners and will soon celebrate 3 years in practice with UHS Rheumatology. It was during her graduate studies that Colette's professional interest in rheumatology was sparked, once again by her mother, who was diagnosed with rheumatoid arthritis. It's therefore no surprise that she's chosen it as the topic of our conversation today. We know that, like Colette, this topic is of personal interest to many of you. Whether you're here with us today because rheumatoid arthritis touches your life in some way or to increase your professional knowledge, welcome. We invite you to ask questions, and if you feel comfortable, please feel free to share your personal experience with us. We'd love to hear your stories. You can do so at any time in the presentation via the chat or by raising your hand, and we'll also allow time at the end for questions and comments. Colette, without further ado, I'll turn it over to you.
Hi, thank you for introducing me. I'm Colette O'Brien. As she said, I work here at UHS Rheumatology, and in August, it will be my 3rd year here. But we can get started with the presentation. The presentation is on rheumatoid arthritis. I did put RA in parentheses because you might hear me call it that instead. But to get started. So what is rheumatoid arthritis? Rheumatoid arthritis is an autoimmune disease in which the normal immune response is directed against an individual's own tissues, resulting in inflammation and destruction. So it usually affects the joints, the tendons, and the bones. One fact about rheumatoid arthritis as well is it is the most common autoimmune disease that you'll see. Like I said, it usually affects the joints, usually affects symmetrically on both sides equally, may initially begin in a couple of joints, but it most frequently affects the wrist, hands, elbows, shoulders, knees, and ankles, as you can see on the image there, the circled areas. So some symptoms with rheumatoid arthritis, the main ones are joint pain, joint swelling, which could include redness or warmth in the joint, and morning stiffness. A couple other symptoms that you may see is pain or aching in one or more joints. Again, symmetrical swelling. You may see some weight loss, fatigue, increase in temperature or fever, and weakness in the joints.
Boy, that covers me.
So what causes rheumatoid arthritis? Rheumatoid arthritis, there really is no cause, it is unknown, but RA, like I said before, is the result of an immune response in which your body's immune system attacks its own healthy cells. The incidence of rheumatoid arthritis increases with age, peaking between the 4th and 6th decades. Usually people are sometimes diagnosed into their 50s and 60s or even later. Again, like I said, it is unknown, the cause is, but they do say that some people with genetic susceptibility do have a higher risk factor of developing it. Again, other risk factors include age, sex, as females are more prone, or women are more prone to rheumatoid arthritis than males, and genetics if there's a family history involved. Diagnosis. Usually we start with a physical exam that would be done by a rheumatologist. We usually look for any inflammatory arthritis involving 3 or more joints. Sometimes we may not see that right away, but usually a physical exam is very important to see the person in person and lay hands on them and see what's going on. Inflammation seen in the blood work, which could include a CRP or an ESR, which are both inflammation markers that can be elevated, whether there's swelling or issues like that, or if you have another infection or illness that's going on, those can also be elevated. We also look for a positive rheumatoid factor or a CCP antibody. They don't have to be positive to make the diagnosis, but that does help us make a diagnosis. There is such a thing as seropositive rheumatoid arthritis versus seronegative, and that basically includes seropositive would be if you were positive for the antibodies, 1, 2, or both of them. Seronegative could be if you were just negative for both antibodies. Another antibody that we look for, another test, is a positive ANA, which can be positive in different inflammatory arthritis and different autoimmune diseases as well, and it can also be positive in the healthy population too, or with thyroid diseases and different things like that. And then the pictures just show a swollen wrist and fingers, along with like a normal hand versus a rheumatoid arthritis hand. So to make a diagnosis, like I said before, we like to start treatment right away to slow or stop the disease progression. Again, a diagnosis is usually made by a rheumatologist. There is not one specific test to make the diagnosis. It's a couple of different things that we look at, like I said before. Going back to the blood work, a rheumatoid factor can be found in 80% of patients. A CCP can be found in 6 to 70% of patients. And again, those inflammation markers help confirm the amount of inflammation in the joints. When we look at the hand x-rays too, generally symptoms are present for more than 3 months, and there's usually classics, like there's sparing of the DIP joints. It more affects the PIP joints and the MCPs. And so the DIP joints are the distal part of the finger, where the PIP joint is the lower part of the finger into the knuckle area. Also, to make a diagnosis, we like to do hand and feet x-rays are what we start with usually. And on those x-rays, we like to look for soft tissue swelling, periarticular osteopenia, loss of joint space, erosions, or deformities. Now, with rheumatoid arthritis, we may not see this right away. Sometimes these are more seen in late stages, as you can see by the picture. These are late stages of rheumatoid arthritis where there's the deformities in the thumb. Another thing we like to call ulnar deviation is when the hand shifts, as you can see where the knuckles are there, where the fingers meet the knuckles, and then a swan neck deformity of the fingers. And those, like I said, again, are usually more in late stages, or if someone didn't receive treatment and things progressed kind of quickly. We may also even see rheumatoid nodules. Now, rheumatoid arthritis does not just involve the joints, it also involves other organ systems. The respiratory system, it can involve the lungs, it can cause some lung scarring and lead you to interstitial lung disease, pulmonary fibrosis, pleural involvement. It can also involve the heart and cause pericardial involvement, any issues with that, pericarditis, issues with the heart, like I said. Kidneys can cause some neuropathy. We do work very closely with nephrology as well, because a lot of our medications do affect the kidney and liver. Again, it can affect the liver, can cause enlarged liver and abnormal liver function. Other things that it can also involve is sometimes it can go in hand with thyroid disorders, osteoporosis, depression, and issues with the spleen. Other organ systems, it also can involve the eyes, causing scleritis or episcleritis, or iritis in the eyes, which is long-term eye inflammation. Usually would need a referral to an ophthalmologist for treatment as well. It can affect the skin, causing leg ulcers, rashes, and nail fold issues. Again, I think I mentioned before, rheumatoid nodules. These can be common, sometimes more in late stages, not always seen in the beginning. And rheumatoid nodules can occur in the eyes, subcutaneously on the skin, the lung, the heart, and occasionally the vocal cords. Neuro-wise, it can affect the peripheral nerve entrapment, some subluxation, and polyneuropathy sometimes is common with these diseases. And here's some pictures of how the eye can look. Like I said, the one on the left is more related to like an episcleritis or long-term chronic eye inflammation with both of these. The second is a little bit more severe and definitely would require a referral to an ophthalmologist for further evaluation. The next slide shows pictures of lung involvement. Again, this is scarring in the lungs from long-term inflammation. That can be from interstitial lung disease, and lung nodules can develop as well. This definitely would need a referral and consultation with pulmonology as well to better assist the patient. Some look-alike diseases that can act or look like rheumatoid arthritis, or people can get confused with them, or would be a viral arthritis that can happen after a viral infection. Connective tissue diseases, like we had talked about previously at the last episode with lupus. Sometimes we'll talk about this more later on, but psoriatic arthritis and other connective tissue diseases. It can also mimic gout, osteoarthritis, which is very common in everyone as they age, wear and tear of the joints. Infectious arthritis also can happen after an infection. Other medical conditions presenting with arthropathy, like I mentioned, would be sarcoidosis, thyroid diseases, endocarditis, and multiple myeloma. How do we treat rheumatoid arthritis? Common rheumatoid arthritis treatments usually would start with a DMARD or some type of steroid. DMARDs are short for disease-modifying anti-rheumatic drugs. This is usually our first line of treatment, along with steroids that we use for more quick relief and short-term use only. We never use them we try not to use them for long-term use at all, as they have a lot of other risk for the patients. Sometimes in the beginning, we do set them up with starting them on an anti-inflammatory medication, which would be like your typical ibuprofens or Advils, and more of a prescription strength. These are usually given, they can be used long-term depending on how a patient tolerates them and depending on kidney and liver function as well. Again, like I said, we usually sometimes have to start with prednisone, which is our steroid treatment. It slows joint damage caused by inflammation, and it can be used in short bursts for flares of any of these diseases. The disease-modifying drugs would be your methotrexate, Imuran, hydroxychloroquine or Plaquenil, sulfasalazine, Cellcept, leflutamide or Arava. These all can affect the kidney and liver function, so we need to be very careful, and we have to check lab work at least every 3 months or more, depending on how the patient's doing. This next slide is our other medications that we use, which are biologic medications. They directly modify the immune system by inhibiting proteins called cytokines, which contribute to inflammation. These medications are a little bit different. Some of them are injections, some of them are infusions, some of them are pills. We usually like to start with TNF inhibitors. It depends on the patient as well and what other comorbidities they may have before starting some of these. There is a couple rare risk factors for them, which would be hepatitis, tuberculosis, and lymphoma. Like I said, they're rare, but it can happen. So in the beginning, to do our testing, we always start by doing lab work to rule out, make sure the patient doesn't have any hepatitis. If any of that does show up positive, we refer and take care of and send the patient where they need to go. We also look for tuberculosis. We actually test for tuberculosis once a year with all these medications, just to make sure that nothing changes and nothing different turns up. Some of the more common medications you might be familiar with would be Humira, maybe Enbrel or Remicade. Some people might see these on the television too, may see commercials on them, which would be Xeljanz or Rinvoq or Olumiant. Rituxan is an infusion. So we can kind of switch in between a lot of different ones. But like I said, it depends on the patient and it depends on what's going on and what's bothering them. Usually we always start with DMARDs, like I said, and then if needed, we add something like a biologic medication in. We also like to use biologic medications if there is a lot of joint damage or erosions seen on X-ray. Again, even though there is treatment for rheumatoid arthritis, there is no cure. This is a chronic disease that the person will have to live with for the rest of their lives. It can go into remission, and the goal really is just to improve joint pain, swelling, and improve your ability to perform your normal activities of daily living and give you a better quality of life. Some other treatments would be more of your non-pharmacological treatments, which would be physical therapy. We work really closely with the physical therapy and occupational therapy offices upstairs and at other offices as well. We have a really good hand therapy group upstairs that helps our patients a lot. We also, if needed, this also can help make a diagnosis as well, is if you come in with a really swollen joint that we look at with the ultrasound machine and we see that there might be some inflammation or fluid that we could pull or aspirate, we always like to be able to do that and send the fluid for analysis to see if there's any inflammation, which can help us as well, or arthroplasty as well too. Sometimes there is a need for surgery. This one would be a little bit more common, would be a synovectomy. And that's usually when 2 or more joints are affected more severely than others. The procedure is used to reduce the amount of inflammatory tissue by removing the diseased synovium or lining of the joint. It can help result in less swelling, pain, and the slowing or prevention of further joint damage. Arthroscopic surgery is always an option as well. This would be more if we had to send to orthopedics. It depends on the extent of the joint damage. It can help to remove loose cartilage, repair any tears, smooth or rough surface, or remove diseased synovial tissue. It is more commonly performed on the knees or the shoulders. Other surgical options are fusions, which would be when the 2 bones are fused together. If there's no longer able to keep the joint from moving, so that would make your finger completely fused if you had a surgery like that. Joint replacement, which would involve, like I said, orthopedics. We usually refer to our orthopedic office right here in the building, which is really nice. They're right down the hall from us. They do a lot of joint replacement surgeries involving the removal of the joint, resurfacing and relining of the ends of the bones, and replacing the joint, which usually can help give the patient a little bit more quality of life and help them move around a little bit better. Usually this is for people for over 50 or who have severe disease progression. Osteotomy is used to increase stability by redistributing the weight on the joint. It isn't often used with rheumatoid arthritis as much because there are other options available besides cutting into the bone, so this isn't really used. A couple of other self-management ideas is really to have a positive attitude, try and focus on other things besides pain, regular medication. The biggest thing is to be compliant with your medication, get your blood work when you're supposed to, and take the medication as prescribed to help slow the disease progression and help with the pain. Regular exercise is good for you. Low impact exercise is best to maintain a healthy weight, which will help better with the joints if you're on a healthy weight. Stop smoking. Use of joints to reduce stress on the painful joints. Energy conservation, avoiding too many activities. So maybe if you have a busy day coming up, try and spread things out so you have time to rest in between. And if you do overdo it, definitely take a rest day, elevate whatever's bothering you. You can use ice, heat, anti-inflammatories, or over-the-counter Tylenol as well. Assistive devices if needed, which would be splints, braces, walkers or canes, whatever you may need. Make sure you're getting adequate sleep. Try and get rest of the joints, kind of like what I said before, to help reduce pain and swelling. An adequate sleep will make you feel better either way for the day. And some relaxation techniques would include yoga or meditation. There is a couple other things. Sometimes people like to try the chiropractor or acupuncture, massage. There is some vitamins and over-the-counter medications that people may try, like ginger, turmeric, fish oil, to help reduce inflammation. There is not a lot of research out there on some of that stuff, but you can definitely try it. It will not hurt. It will not hurt anything to try something like that. And then I think that's about it. So that's really just the basics about rheumatoid arthritis. If anyone has any questions.
Colette, thank you so much for this, all this great information. If anybody would like to ask a question, you can feel free to unmute yourself, or you're also welcome to ask it via the chat. All right. All right. Well, I'm going to go ahead and take us off record. That may prompt some people. Oh, let's see. Do you see a lot of success with splinting?
A lot of success with splinting. If it's necessary, I guess it depends on what's going on. If there's a lot of arthritis, if we do refer you to physical therapy or hand therapy, they usually help with deciding what's necessary and what type of splint the patient may benefit from. They actually can make a lot of their splints right up there in the therapy office, which we got to watch them do all that, which was pretty nice.
Yeah, I would say the splinting and indication, depending on the joint and the level of function of the patient, how essential is the joint involved in the day-to-day activity. We definitely see a resolution of synovitis and inflammation in the joint with systemic steroids a lot quicker and faster than any conservative management with the splinting. But in some cases, let's say allergic reaction, limitation in the use of systemic steroids or NSAIDs, that's when these conservative management can only be beneficial, even if they're slow in action.
We do have another question in the chat. I'm assuming there's no cure for osteoarthritis except replacement when there's nothing left of the joints, and a question about gel injections.
So no, there is no cure of osteoarthritis either. Osteoarthritis is the wear and tear on your joints after years of, if they played sports or anything else like that. If there's nothing left of the joint, we could refer to orthopedics for them to evaluate the patient if they need surgery, if they're a candidate for surgery. Before that, we can definitely try injections to help with pain and inflammation and kind of coat in between the gel injections. So we can try gel injections too. Usually we would start with cortisone injections first. And if the patient failed that or it didn't help, then we can always switch to something else. There's gel injections, Symvisc 1, Euflexa, and sometimes orthopedics does some different type of injections like that too. And we can do them under ultrasound as well.
Okay, and then there's another message that I received. My mother has RA and SLE. I was born with no thyroid and have had issues, but have never tested positive for either disease. Is there a correlation between thyroid and AID?
a correlation between thyroid. What was the other thing?
Autoimmune disease.
Oh, autoimmune disease. Okay, I didn't hear that part. There could be, some people do have thyroid disease, and if it's an autoimmune thyroid disease as well, and autoimmune disease, but you might not always, she may not test positive for, she might not have those antibodies as well for lupus or for rheumatoid arthritis, or maybe it didn't present itself yet too. Things can change over time.
So we do not screen for lupus and rheumatoid arthritis if patients are asymptomatic, even if you have a family history of those. That's kind of, I think, the first message that we want to make sure that it's out there. Thyroid disease, like Colette was saying, could be autoimmune in nature, which not always the case, but if it is autoimmune in nature, having one autoimmune disease can put you at the high risk of having another. But it doesn't necessarily mean that we should be screening for those, even if the patient is asymptomatic. And that's where it becomes a little tricky, where, the patient is worried about these things and how to plan or how to explain things. So regular follow-up with your specialist or primary care provider will be the best way, where the communication is started and you'll be taken care of regardless of symptoms or no symptoms, right? So the decision will be depending on what the provider finds in the history and exam that makes them make the decision of, do they need to test for these things and how often or when?
And they had a follow-up comment just saying that they have had nodules, and I'm going to butcher the pronunciation of this, uveitis, uveitis, but my blood tests are always normal. All right.
So uveitis on its own could have an autoimmune etiology. Thyroid nodules as an information is not really enough where to say, is that autoimmune in nature or not? But I will say your best kind of way to maybe discuss with the endocrinologist, if you're seeing one, on what is the best way to proceed, along with the communication with the ophthalmologist, because they are providers where they can initiate testing, and we get quite a bit of referral from ophthalmology to help them either for further evaluation of the possibility that this uveitis autoimmune in nature. So it's either for further workup or even co-management. So we work hand in hand with the eye doctor in how best to treat and keep the eye inflammation under good control when patients fail topical treatment. So if these drops that they're giving them control the symptoms, then they don't need to come and see us in a way. But if the topical treatment can't control the symptoms and they need something orally and systemic, or they have other symptoms worrisome for other autoimmune disease, then they can send to rheumatology. Very, very interesting question.
We do get a lot of referrals for that too, like she said.
And just for those of you that don't know, that was Dr. Henda Bouali, one of Colette's colleagues at UHS Rheumatology, adding her insight. And we do have another a comment, more than a question, in the chat. I'm a fairly new patient at UHS Rheumatology, and I'm pleased with the care I get from Dr. Ludo. I know Dr. Ludo is on here with us today, and she'll actually be presenting on gout and pseudo-gout later in the series in July. All right, wonderful. Any other questions or comments? I see some other messages saying very informative, and thanks to Colette.
Yeah, that was a very nice presentation, Colette. Thank you.
Thank you.
Excellent. All right. Well, with no further questions, I'd like to say thank you once again to Colette and her colleagues at UHS Rheumatology, and to each of you for joining us today. We've had a really nice mix of UHS and CMH employees, as well as patients and community members. It's been wonderful. We hope you'll join us for the next installment of this series on Tuesday, June 15th. Dr. Pawaskar, also on today's session, will be presenting on polymyalgia rheumatica and giant cell arthritis. Hopefully I pronounced those correctly. To register, call 607-337-4183 or email melissa.stagnaro@nyuhs.org. Thank you again for joining us today. We hope to see you for our next installment of Lunchtime Learning, brought to you by UHS Chenango Memorial Hospital and the UHS Rheumatology team.
Thank you.
Thanks.